website, it clearly states that the United States Preventive Services Task Force recommends against routine screening mammography in women aged 40 to 49 years. Do you think that this statement could be perceived by women younger than 50 that they should not get a mammogram?
We need to immediately figure out how to get that statement off the website. I think it could be misconstrued. It has been misconstrued, and we need to fix our website.
Dr. Petiti, I thank you for that response, and I hope that you will do that. I think it's very important. I agree with you. I want to ask you, Dr. Colon, are you aware that the Senate version of health care reform, specifically Section 4004, I think is on page 1150, it requires the Secretary of HHS to create a national prevention awareness campaign based on all of your task force recommendations, both those that you favor, the A's and B's, and that those you recommend against, the C's and D's. Do you think that this national awareness campaign could be perceived by women younger than 50 that they should not get a mammogram or perform a breast self-examination?
I wonder if, Congressman, if it would be okay if you restated your question, because the first part of it and the second part I didn't.
Well, what I'm saying is in the Senate bill, if it becomes law, if that prevails, the Senate language in the conference report, it becomes law. And it specifically says, and I named the page and section, that the Secretary would require the creation of a national prevention awareness campaign, television ads, TV spots, based on all of the task force recommendations, both those that you're in favor of and those you recommend against. Don't you think, or do you think, this national awareness campaign could be perceived by women younger than 50 that they should not get a mammogram, nor should they perform self-breast examination?
Thank you for the clarification, Congressman. So I can't speak specifically to the bill or to the policy. I will speak to the communication of the recommendation, which we believe needs to focus on the decision to start regular biennial screening before the age of 50 should be an individual one and take patient context into account, including the patient's values regarding specific benefits and harms. And so that message, which I realize is preceded by the recommends against statement, is one we feel communication needs to be improved, and the clear message of what the task force intended needs to lead that, not follow.
Well, thank you, Doctor. Mr. Chairman, if you'll bear with me just for maybe 15 seconds, I had one other point I wanted to make. The United States Preventive Services Task Force concludes that the current evidence is insufficient to assess the additional benefits and harms of clinical breast examination beyond screening mammography in women 40 years or older. That is saying that you don't recommend that the clinician, a physician, primary care physician, OBGYN specialist should routinely do a breast examination as part of a complete physical in his or her patients? That has no value?
The evidence does not provide support for a clinician doing a clinical breast examination.
Well, I thank you for that response, and your honesty, Mr. Chairman. I know I've gone beyond my time. I appreciate your patience. I think that's terrible, and something needs to be done about that.
Next is our Vice Chair, the gentlewoman from California, Ms. Capps.
Thank you, Mr. Chairman. I just want to say thank you to both of you for being here, for your excellent testimony, and for being among the few on Capitol Hill who apologize occasionally, and it's not a habit that we do very well. So the fact that you, I wouldn't call it an apology as much as acknowledging the communication glitches that occurred perhaps, and for me, I think it was a lot of it being timing. But I don't take it as a negative thing. I think we are seeing as a very positive overall experience happening in our country, not to minimize the confusion that many women experience, but I think we can use it as a teachable moment, let's put it that way. The timing of the release of the report and the debate on health care reform has been seized by many who want to detract really from the health care legislation to use your testimony in widely misconstrued ways. And I want to take a minute of my time to mention one very important distinction, but it's also an important point of what the health care reform bill is, which actually will be augmenting a lot of the preventive work that you're doing, because women will be able to have an occasion to understand more about cancer prevention in its wider forms and their behaviors and their body changes, which are all essential. But the essential benefits package in the exchange consists of 11 benefit categories, including inpatient hospital services as examples, outpatient services, maternity care, prescription drugs, as well as preventive services. But with regard to preventive services, the bill says that the recommended items and services with a grade of A or B from U.S. Preventive Services Task Force shall be covered as part of the essential benefits package, a rightful designation of the importance of your studies and your recommendations, but not a conclusive piece of it. And that this be something which we highly recommend, that there be no cost sharing for this grade A and B of your recommendations. The Benefits Advisory Committee, part of the health reform, will be able to recommend through its public standard setting process that additional preventive services, such as mammograms for women under 40 or between 40 and 49, be covered without cost sharing. I mean, there's an additional recommendation that can come as part of the health care bill. The Secretary may also approve such coverage. The essential thing here is that the benefits package, essential benefits package, is a floor, not a ceiling. And that really is important for, I want the record to state that very clearly. Employer, once the exchange goes into effect and there's real competition between private insurance plans, they may wish to offer more attractive packages to win more, coverages, so that it might be understood more fully as we go along this debate. I just wanted to make sure that that be in the record. But I wanted to give you even more opportunity, both of you or one of you, to talk about what the future could hold. You see, I think this is an opportunity, a wow moment, as one of the advocate groups put it. And I want to commend all of the breast cancer advocacy groups who have brought us to a level in this country where, when a set of recommendations like yours comes out, that there is a more intelligent audience receiving it, able to understand it, and able to use it and to advocate even more in a wide range of ways, which I think is very healthy for our country to be a part of. I'm only giving you about a minute, but I'd like you to elaborate further on ways that your task force can communicate in the future in ways that maybe we can access and use more efficiently.
Well, what I thought would happen with these recommendations is that it would move the discussion more towards the notion of individualized decision-making and risk stratification. What I thought is it might initiate a dialogue where we decided to work harder at finding out who really is at higher risk so we could make more tailored recommendations for screening. And among those groups that we really have ignored are African American women who are
Absolutely.
younger and women of Ashkenazi Jewish background, some of whom have a very high risk based strictly on their membership in this group. Again, what I thought would happen would be a move towards individualized, tailored, risk-stratified decision-making, and not this sort of rehashing of a bunch of old data.
Dr. Kalanj, would you like to add anything to that? And I know I'm squeezing a few more seconds. I think this is really important.
I want to echo the issue about individualized decision-making. I think we hear a lot about personalized medicine, and I think the basis of personalized medicine can be and should be individual-based decision-making. And it's really what we were hoping the language for the younger age group would start engendering, this issue about, we as consumers of healthcare should kind of understand that every test we have and every treatment we have has both inherent risks and benefits. And we should make our decisions based on understanding those and then what's important to us.
And that underscores the value of the work that you do in this topic and in every other topic, and the importance of having educated health in areas of health, a population that can seize the material as well as primary care providers and other doctors as well, who use your information every single day to make the kind of informed decisions that they and their patients need to have before them. So I hope this can be the beginning. I again want to thank our chairman. This is the kind of setting, this hearing setting, that is so important for us to take advantage of and use your expertise and your research and have this kind of debate, if you will, but discussion. So I thank you again for being here.
Thank you. Mr. Rogers.
Thank you for being here, and I have some quick yes or no questions, if I may, just to get through it. Were you familiar with the references to your task force in the bill as it was introduced in July?
No.
No. So you knew nothing about the over a dozen references to your task force in this bill?
I hate to say, but I was busy preparing a course in biostatistics, and the answer is honestly no.
Okay, and is that consistent through the whole task force or any of its representatives or administration thereof?
I hesitate to have the two of us represent the opinions of all the rest of the task force.
But it wasn't part of your discussions? Was not?
In July? Absolutely not.
Okay. Are you aware that in this particular bill, and I think maybe the chairman our healthcare committee chairman was mistaken, and I think the chairman emeritus was mistaken. This is not necessarily a new committee. They may create a new name, but in the bill, and I'll just read right from the bill. The Preventive Services Task Force convened under Section 915A of the Public Health Service Act, and the Task Force on Community Preventive Services, and then in quotation marks, as such section and task forces were in existence the day before the date of the enactment of this act, shall be transferred to the Task Force on Clinical Preventive Services and the Task Force on Community Preventive Services, respectively, established under these sections. And then it goes on to say that whatever your recommendations were prior to that enactment are in effect. Are you aware of that, sir? Or ma'am?
Well,
yes
certainly...
yes or no? I'm sorry.
Yes.
Yes.
I'm now aware of it.
But were you aware of that during your deliberations?
No.
Okay. Would that have changed your deliberations at all?
I can't speculate on what might have happened.
Interesting. So what you're saying is that according to the law of which this committee wants to enact, you have now taken ages 40 to 49 and made them a Category C, which means they will not be paid for under this committee. That's interesting. And let me ask you this. You say you didn't consider costs. Is every appendix that is attached to your task force recommendation, is that something that would have been reviewed by the individuals who made the determination? Is that something of value? That's why you attached it as an appendix, I imagine?
Yes, all the material and evidence is germane to the decision.
Perfect. Thank you very much. Are you familiar with Appendix C1, where the question is, what is the cost effectiveness of screening that assigns a dollar value by quality of years of life? Are you familiar with this? This clearly is a cost-effectiveness portion of your study. Clearly, you cannot in good conscience tell this committee you didn't consider cost. You just told me that every piece of information according to your study is considered. This is a dollar value per quality of life, and it's done on mammography screenings.
The committee...
Will you remove this from your task force study as well, as your recommendation that said that
I'm sorry, but I'm trying to see what you're pointing at, and
it's Appendix C1 of your own task force recommendation that clearly considers costs just by your own testimony. And again, you can see why women of America and those of us who are very concerned about bureaucracies interacting between health care, on your website, again, you say that you recommend against routine screening. You say that you're going to take that off. That's great. You say that, gee, we didn't consider costs, but on your own report it says you considered costs. You can see why, after we're creating 118 brand new commissions just like yours, all of your authority will now be enacted into law, according to their own bill, by the reference I've just read. I mean, that's pretty serious. And let me ask you another question. As a part of this, it says, and I'm going to read this again from the bill, because I think some of my members on the other side maybe either haven't read the bill or maybe misunderstand their own language. But even under this is the Indian healthcare section, Section 206, I would encourage you to read it, under mammography and other cancer screening, the Secretary shall ensure that screening provided for under this paragraph complies, meaning you got to do it, with the recommendations of the task force with respect to A, frequency, B, the population to be served, and C, the procedure or technology to be used, all of which is referenced in your report. Imagine that when this passes, your report now becomes a matter of law, according to their own language in this bill right here. Would that change your consideration as a scientist, knowing, as by your own testimony, it did not pass unanimously? You say science and evidence, but clearly people of equally as learned as both of you believe that that was the wrong answer? I mean, is this something you should reconsider?
Mr. Rogers, look.
No, I would like an answer to
No, I know, but I'm going to ask you to go beyond that. I mean, you used your 5 minutes. You take what time is necessary to respond, because I'm not sure you even know what the questions are, but please take the time.
I was going to
I
say
got my
that.
yes and no's.
There were a number of different questions, and I'm not sure which one to respond to. What I would like to say, and I want to say it again on the record, that when we voted the recommendations for mammography screening A, B, and C, we voted them without regard to cost or cost-effectiveness analysis. I can say that the word honestly, absolutely, the word cost was not in the room, it was not mentioned, it was not uttered, and it did not in any way determine.
But it was part of your study, was it not? Was it not part of your study? You just told me that everything that was in your study was considered. Appendix C1 considers cost. How could you?
All right, look, Mr. Rogers' time is up. You can respond and say what you want, but we got to move on.
Mr. Chairman, if you'd like.
I have nothing more to say.
Yeah. Mr. Rogers, I'm just trying to make sure she is able to respond, but I think we should move on because we're a minute over now, and I think she doesn't want to say anything else.
Well, Mr. Chairman, my only caution here is that,
I understand what you're saying.
I do believe the intention of the other side is real. I do believe that. But the language of the bill, of which I believe that most members of Congress have not read.
But she has repeatedly said that the bill, she didn't even know what was in the bill, and their deliberations were done under the previous administration before President Obama was even President of the United States.
But, Mr. Chairman, the point here is that she did say that the cost wasn't as part of their voting, but it certainly was part of their report. That's very important knowledge for all of us to know when we raise questions about adding, when you change.
You made your statement. She responded to it. Let's move on. But I can't help but repeat that their deliberations, as they said, even preceded the current administration. But whatever, let's move on. Next on the Democratic side is the gentlewoman from the Virgin Islands, Ms. Christensen. Your mic not working there? What happened?
It's on now, right? Thank you. Thank you for your presentations and your answers thus far. But I want to go back to the issue of African American women. Some years ago, many of us worked to ensure that mammograms would be recommended and covered for women of African descent under age 40. And given that even though we may have a lower breast cancer incidence, we're more than likely to be diagnosed at later stages and have a higher mortality rate. And even in younger women, we find that younger African-American women are more likely to be diagnosed with breast cancer. So in the recommendations, why wouldn't the task force single out this particular group and maybe give them a different recommendation rather than lumping all women between 40 and 49 or younger under C or I?
You make an excellent point. And I think, again, what I expected to happen with these recommendations is that we would begin to focus on how to make more stratified and nuanced recommendations that would identify those groups who are unrecognized as being at higher risk of consequences of breast cancer when diagnosed at a young age.
So even though the bill says in the Indian Health Service that your recommendations would be applied, you might look at the Native American population as a group and decide maybe a different grade for different age groups in that particular age group and make that recommendation. Might that not happen?
Yeah, I think that the accompanying editorial to our recommendations pointed the direction that we thought we would be going after these, not in Congress trying to defend them, but moving to the point where we have more individualized risk. And I would say that based on my understanding of the science, which I follow very closely, that breast cancer in young African American women is a topic which is not widely appreciated as being one which perhaps needs a different kind of recommendation. Again, we need to do better at the risk stratification and individualized risk. I can't say the task force is going to immediately be able to go back and
I understand,
do something.
but you recognize it, and this is not the final answer.
This is definitely not the final answer. I think people would have wished that we would have not even ever opened this topic again after 2002.
Especially not right now.
Well, that was an accident.
But given what occurred in response to the article and the press taking it up and how it has been interpreted, have you looked at other ways of presenting recommendations that might be controversial? I've never really liked the fact that the press really gets these advance notices and they start to tell us what is coming up in the next medical journal because they don't really understand it.
Well, we communicated very poorly. We should have spent more time talking with our stakeholder groups. We should have had a formal communication plan both to consumers and physicians.
I agree. Can you explain how that the overdiagnosis is a bit confusing? Can you explain how overdiagnosis occurs when DCIS or early stage lesions, especially in a younger individual is diagnosed and treated? Because my understanding on the DCIS is that it's likely a precursor to invasive cancer. So is the task force saying that it might be better to not diagnose it, or if you think it's there, to leave it alone and not do further investigation or remove it? Because I would think, and anxiety is one of the issues that you raised, I would think it'd be more anxiety-provoking to think that I had a CA in situ or early stage cancer and sit and wait on it rather than to have it biopsied and removed.
Well, here we're definitely getting way out of my range of expertise. This is a topic which I would want to have addressed by a medical oncologist and those who are now working so hard to try to understand better how we separate and differentiate those tumors that are going to progress rapidly and those tumors that aren't going to progress. But this is outside my area of expertise.
Well, speaking to a surgical oncologist actually yesterday, they feel that DCIS is many times a precursor to invasive cancer, and I'm surprised that it's listed as one of those things that maybe we're overdiagnosing or overtreating. But I think my time is up, so thank you for your answers.
Gentleman from Arizona, Mr. Shadding.
Thank you, Mr. Chairman. First, I have to express some sympathy for you. You stepped into a controversy which has been made much larger as a result of the overall health care reform that's going forward, and I think that to a certain degree you've been sucked into a much larger battle than your own efforts to try to make recommendations would have otherwise merited. As I understand your recommendation, you base it on science and you say, look, here's what we have concluded based on that science. It shouldn't be automatic. It ought to be something you think through, and here's our recommendations. That makes a lot of sense to me. I presume from that you believe that it should be a decision between the patient and her doctor, and that, for example, if a particular patient had a history of cancer or breast cancer, then you might get screening at a younger age, or in some of the categories where you didn't feel it should be automatic, but under those circumstances it should occur. Is that correct?
Yes, that is correct.
Okay. You would then agree with me that if the government were to prohibit an insurance plan from providing coverage for someone who, after consulting with her doctor or looking at her family history, thought she needed it, that would make that at least not an insurable event, correct?
I am not here to get involved in the coverage and the
Right.
health care reform coverage issue.
Fair enough. I will just then state for the record that in my view, the government should never prohibit someone, and the government should never be able to prohibit someone from offering mammogram coverage or as an insurance company or a public plan, nor should it be able to prohibit an individual woman or her family from deciding they want to purchase mammogram coverage. And I am deeply troubled that this bill, which seems to be the larger context into which your work has been reported, does precisely that. I do want to say that it is important, Mr. Chairman, that facts be abided by, and unfortunately, in a piece of legislation this size, it's subject to interpretation and it's subject to quick review without people being very precise in their language. I want to make it very clear. I mean no personal offense by this, but there have been things stated in this room today that are flat untrue. For example, the chairman said that if a C option, you have your A and your B and now a C, is determined by the secretary to be covered, it is to be covered. That is in fact flat not true. The only way a C option can be covered under the language of this bill is for two things to happen. First, the Health Care Benefits Advisory Committee has to say, contrary to what the bill says, we think it should be covered, and then the secretary has to say it. So it's not a single decision by the secretary. Second, and I'm sorry he's not here, but the chairman of the full committee came and made an adamant argument, which has been repeated several times here today, that the bill prescribes minimum benefits, and therefore to say that coverage of mammograms is not prohibited is untrue, that all the bill does is prescribe minimums. That also is flat not true. If you go to page 169 of the bill passed by the Congress, you will discover, as I mentioned earlier, that there are 4 levels of plans. There is a basic plan, an enhanced plan, a premium plan, and a premium plus plan. The basic plan can only cover A's and B's, the things you recommend to be an A or a B. It could cover a C if the 2 exemptions I just pointed out were to occur. But the basic plan, absent those 2 things happening, does not cover anything but A's and B's. But more important than that, the definition of enhanced plan and the definition of premium plan both prohibit any additional benefits. They say you can have an enhanced plan and you can have lower cost sharing. You can have a premium plan and it can have lower cost sharing. But it can only cover the basic services. So all 3 of the first levels of plans are prohibited from covering any service other than an A or a B. Only until you get the definition of a premium plus plan, and I would point the chairman of the full committee to page 169, lines 20 through 25, does it say a premium plus plan is a premium plan that also provides additional benefits. That's the only plan that can provide a benefit beyond the basic plan. And therefore, the first 3 levels of plans are prohibited from covering mammograms by law, whether they're offered by the government or offered by a private insurance company, whether they're in the public plan or in a private plan, they are prohibited. And that may not be the intent. As the ranking member, Mr. Barton, made very clear, we need to deal not with we need to deal with what the bill says, and if it does not reflect our intent, and I would hope in this case it doesn't, because I don't think the government ought to be in the business of telling people you cannot buy coverage for mammograms, then we need to fix the language of the bill, or at least talk truthfully about it. And the chairman of the full committee was wrong when he said that this sets only minimums. There are words at the beginning of the bill which refer to minimums, but the words of the bill specifically say it can only cover those items with the exception of when both the Secretary and the Health Benefits Advisory Committee decide to cover a C. And I appreciate the opportunity to put that into the record. Thank you, Mr. Chairman.
Thank you. I don't want to keep belaboring the point, but the reason I responded to your statement and said that there were situations where the Secretary, and now you're saying the Advisory Commission, could add it to a basic benefit package, was because when you made your opening statement, you suggested that it couldn't be done that way, that they couldn't include it. So, I mean, I don't want to belabor the point. I don't disagree with you, but you're disagreeing with yourself because you initially said that they couldn't add it as a basic benefit. Now you're saying they can.
If the gentleman would yield.
Sure.
I actually didn't say they couldn't add it. I didn't discuss whether they could add it. I said that the basic plan cannot offer it. And it cannot offer it absent extraordinary circumstances, which are two other things.
Well, I think we're saying, I think.
And I think what we're
I think the problem is we're saying the same thing, but I'm not going to get into it. I don't think there's any difference between what you said and what I said. Right,
let's agree on that. But let's agree to fix it so that the bill doesn't say that someone cannot choose to buy a plan. For that matter, let's allow people who get a public plan to get mammogram coverage.
I'm not going to continue to belabor it because I think that we're not necessarily disagreeing on whether it could or could not be included. The next person is the gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman, and thank you very much for your testimony today. I believe the larger issue is the lack of access to any screening or health service for millions of American women of all ages. And I'd like you to comment upon the implications of your latest recommendations on the millions of women who are not being screened at all. What do you say to them, no matter their age?
You know, again, the task force can't fix these problems. I'm here as a member of the task force speaking to mammography guidelines and speaking to the evidence we use to make them. There are clearly huge issues facing this country about health care and health insurance and health policy, but I'm not an expert in that area.
If I could just add to the point that it's clear that the provision of mammography and screening for breast cancer extends life. And so that's the service that we recommend. And I think everyone in the room knows that and needs to keep in mind that if the idea is to maximize health and extend life, then the services that are recommended should be considered for provision.
I mean, your recommendations talk about how, for example, the age 40 to 49, how it is important for women and their doctors to have these, to have a personalized plan with their trusted physician. But there are many, many women out there who don't have a trusted physician. They don't have, they're not receiving their checkups. Certainly you all have something to say to women all across America, no matter their age, on being as proactive as they can, taking personal responsibility, finding that you must have something to say on higher risk groups to help us communicate in a better way. You've already acknowledged that you did not do a good job in communication, but here's your chance today to bring all of your expertise and to provide a message to women on the importance of taking personal responsibility and getting their screenings. They may not have access to care, but there are wonderful nonprofit groups where they provide some services in communities. Can you at least go that far and provide a proactive message to women in this country on the importance of taking care of themselves and seeking out these screenings?
Well, again, I feel uncomfortable in being asked to put on a personal hat rather than my task force hat. I would be remiss if I didn't encourage women to be interested in their health, to take care of themselves. But I'm here as a member of the task force to speak to the mammography guideline recommendations and not to go beyond my expertise. I have friends who have no insurance. My daughter is uninsured. I know women who are uninsured and can't get surgeries they need. But that is not my role here. My role here is to speak to the mammography guidelines.
you're familiar with the huge disparities in screening, diagnosis, and treatment among various income levels, and if you're African American, you're Latina, correct? You have.
There are disparities in health care throughout all services.
If you could go back, or will you go back and review your recommendations along the lines of higher risk groups, what we know on disparities of screening, diagnosis, and treatment? Don't you think you could have done a better job in fleshing out some of those recommendations?
I think on many levels we know we could do a better job, and among them is the communication. We need to, we have tried for a number of years to make our recommendations more risk stratified. For breast cancer, this has been perhaps a little more difficult than for some other topics like osteoporosis. But again, what I thought would happen with these recommendations is we would start having exactly this kind of discussion. How do we find women who are at extremely high risk? How do we communicate with them effectively? How do we make screening mammography something that is more individualized and tailored?
Thank you.
I would only add to that a plea for consideration of research of preventive services in the specific populations who are underrepresented in screening and other prevention studies. We often fail in this area, and I will inform the committee that we have a discussion about health disparities associated with nearly every recommendation vote. And the frustration on our point is the lack of evidence of efficacy in a specific trial aimed at high-risk populations. So I think this is a consideration of the task force, and as we are evidence-based, this is a real plea on our part for researchers and funders of research to consider adequate studies that include disparate groups for where we are concerned there may be differences and require different recommendations.
Thank you.
The gentlewoman complete? All right, thanks. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I guess you're not used to women speaking a little more quickly and being a bit more succinct. So maybe that's why we have time left many times. I want to thank you all for your patience and your endurance today, and I really want to thank you for being here. This is an issue that is of tremendous concern to us. And as we look at what your findings were, and as we look at the language of the bills that are before us, I think what we want to make certain we do is if there is offending language in the bill, we want to get it out. And, of course, we want to make certain that we have a clear understanding of what you brought forward and of your intent. And I'm going to try to be succinct on this because I do know you're ready to move on, and we have another panel. Dr. Burgess had asked that you submit the vote from your committee as you arrived at your finding and your guidance that you made public. And as you submit that vote, who voted and how, one thing I would like for you to do for the record is also submit to us your science or evidence upon which you based these recommendations. What was reviewed? What studies? What findings? What groups? If we can have that as a part of the record so that we can look at it, I think that would be very instructive to us as we decide how to best move forward. So I would like to ask you all to do that. I'd also like to know what period of time, how long did you spend on this? How long was this up for discussion and under review? What was the thought process and the matrix that you worked from to come to this decision. Let us see a little bit about what you went through and how you went through it, how you work, what your process is, how you arrived at those decisions. I do honestly believe that will be helpful to us with an understanding. I will have to say I agree with some of my colleagues. You probably stepped into a bit of a quagmire that you did not expect as you release these findings. And I'd like to ask you, were you all aware of how the H.R. 3962, how it would affect you, how your task force would be drawn into that bill, that the language of 3962 actually pulls you in, renames you, and then gives credence to these findings through statute?
Well, as unbelievable as it may seem, to those who are so caught up in Washington, I was writing my biostatistics lectures and have been actually woefully and naively oblivious of what's been going on in the healthcare reform arena. Certainly from the point of view of specific statutory language in this, now what I know is a 2,000-page bill, I knew nothing. And quite honestly, when I found out that these recommendations were being released the week of the vote, that was the big vote, I was sort of stunned and then also terrified. And I think my being terrified was actually exactly the right reaction.
Dr. Colon.
I would like to add again, speaking specifically to the timeline for the consideration of this recommendation, that it was completed prior to any sense that the role of the task force might change under upcoming healthcare reform. I will say that earlier this year we became aware of language in the House bill regarding the recommendations of the task force. However, this recommendation was considered and voted on with our explicit scientific methods well before that.
Okay. I appreciate that, and I do thank you all for your sensitivity to this. I think the linkage that exists with the language of changing your title and then giving credence in the force of law, basically, to the priority assignments that you would make is of concern to us and to our constituents. I thank you all, and I'm only going to yield back 18 seconds, but I yield it back, Mr. Chairman.
Thank you. Oh, I'm sorry. The gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman. Just so I understand this correctly, the task force has been charged with developing a scientifically determined floor for preventative services in this bill. I mean, is that your understanding of your role?
You know, I'm realizing that I really don't understand the bill. I shouldn't speak to the bill. I've learned a lot about the bill here.
Well, the bill itself does, in fact, vest that kind of power within the task force to develop a scientifically determined floor, in other words, a minimum threshold under the basic coverage. Those recommendations then follow to the Benefits Advisory Committee. Your recommendations will establish a floor under which the Benefits Advisory Committee cannot go. They can go higher, however. Once the Benefits Advisory Committee, and by the way, the Benefits Advisory Committee consists of private medical doctors, patients, employers, insurance experts, a dentist, and representatives of relevant government agencies. It's chaired by the Surgeon General. Once it issues its recommendations, the Secretary, those recommendations then are the floor. The Secretary then has the discretion to increase or enhance the coverage available in the basic essential benefits package. Once that has been established, private insurers have the additional option of offering more coverage. So the suggestion that because your task force has issued the recommendations that it has, no insurance policies will cover mammograms for women in these categories, or even the suggestion that the essential benefits package as established by this bill will not cover them, is preposterous. There's no truth in it. I do have a specific question I'd like to ask you regarding some confusion that your findings have created back home in my district. There was a recent letter to the editor very widely distributed regarding your findings that have created some confusion. I'd ask that you try to clear this up for us. The author of this letter writes, this is a quote, "What's most troubling about the federal panel's recommendations is that they are based mainly on cost saving," end of quote. She also expresses concern that the recommendations are, quote, "cost saving measures," end of quote. Can you tell us today, in no uncertain terms, what the role of cost of mammograms played in your investigation and findings?
This is an easy question. Cost played no role in our recommendations. Again, and I've said it publicly in other settings, and I'll say it again here, I think I've said it 3 times here, cost was not a consideration in the voting of our recommendations.
Thank you. And finally, the author of that same letter pointed out that the task force contains, quote, "no cancer specialists," end quote. This is obviously a point that would be disconcerting to many. Is it true that no members of the Preventive Task Force have any experience in working with cancer?
That is incorrect. Members of the task force consist of myself. I was the vice chair of the National Cancer Policy Board. One member is a member of the National Cancer Institute Board of Scientific Counselors. Another member, current member, is a professor of, he's the Associate Director of Population Sciences for the Dartmouth-Hitchcock Comprehensive Cancer Center and an endowed chair of oncology. Again, the members of the task force have the expertise that permits them to make the kinds of recommendations they made within the arena of screening and preventive services.
Thank you, Doctor. I yield back my time.
Thank you. The gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and I know I'll be as quick as we can. I want to welcome our doctors, and I guess having served on this subcommittee for 12 years now, and the release from the USPTF probably got more coverage than anything our subcommittee's done, except the health care bill, and there was a lot of misinformation about it. But in your testimony, you say that individuals representing the views of the American College of Obstetricians and Gynecologists and the American Academy of Family Physicians weighed in on your recommendations, and the obstetricians and gynecologists expressed concerns with the wording of the recommendations. Do you believe that in the future it would be a good idea for the task force to actually have individuals from these organizations, such as these as actual reviewers instead of commenters?
Well, I want to clarify that they were official reviewers. First of all, as I pointed out, there were 2 members of the American College of Obstetricians and Gynecologists on the panel. They were official, the ACOG reviewers were official reviewers. Okay. They made a number of comments. One of their comments, which was the most substantive comment in retrospect, was about their anticipation of misperception of our C recommendation, and they were right. And we should have listened more carefully to them, and I'm sure we will listen more carefully in the future.
Okay. And I think there was misinformation, I guess, on the self-exam, the information. And from what your testimony earlier was that, physicians need to be able to provide the expertise on so women can do the self-exam. It's not perfect. If there's a question, then they ought to talk to their physician, and that's where it goes from there. It's so that's why I don't understand the fear of the self-exam. But my last question is, a major concern I have is the lack of transparency of the process within the USPSTF for deciding whether or not to change or create new screening recommendations. And depending on what happens with the health care bill, your initial decision could make a big difference. How could the task force be more open to outside input and feedback, and what changes would you make in the future after what you've learned from this experience?
Thank you for this question. The task force understands the criticisms regarding transparency. As our profile has been increased during the discussion of healthcare reform, we believe it is incumbent upon us to increase our transparency in such a way that people understand, as previous Congresswoman asked, how we get to the decisions that we get to. The task force is already working on new transparency approaches, including allowing internet-based public comment on different work products. We think that's a good step. We're cautiously trying to expand into areas of transparency to include potentially public commentary during meetings and other approaches that we believe meet the intent and the requirement for transparency, so that the decisions are made in such a way that we're not spending time in front of the public trying to help people understand the processes. So we understand this criticism. We actually started working on enhancing transparency about a year and a half ago, and I will only tell the Congressman that our slow working has to do with understanding the resource impact of becoming more transparent. But we absolutely believe we need to do it, and we're working towards that end.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you, and I think that concludes our questions. But let me just thank both of you, really. I think that you did a tremendous job today of clearing up a lot of misunderstandings. And as someone who's been in politics, I guess I could say my entire life, I think it's kind of refreshing to find out that, you know, you really were very independent and not at all aware of what we were doing. I think we give ourselves too much importance. You know, we all think we're so important that everybody's paying so much attention to everything we do. It's kind of refreshing to know that you were not. Thank you. And I'll ask the next panel to come forward. Let me welcome our second panel and introduce the panel. Beginning on my left is Dr. Otis Webb Brawley, who is Chief Medical Officer for the American Cancer Society. And next is Jennifer Luray, who is President of the Susan G. Komen for the Cure Advocacy Alliance. And then we have Dr. Donna Sweet, who is a member of the American College of Physicians Clinical Assessment Efficacy Subcommittee. And finally, Fran Visco, who is president of the National Breast Cancer Coalition. I know some of you have been here before, and thank you for being here. You know, I won't repeat that we ask you each to keep your comments, if you can, to 5 minutes. They become part of the record, and if you want to, you can submit additional written comments later. But let's start with Dr. Brawley. Thank you.
Good afternoon, Mr. Chairman and distinguished members of the committee. I'm Otis Brawley, the Chief Medical Officer of the American Cancer Society. On behalf of the 11 million patients and survivors in America today, the Society thanks you for your continued leadership in the fight against cancer and your commitment to enacting comprehensive health care reform legislation this year. I appreciate the opportunity to testify today about the important role mammograms play in combating breast cancer deaths. As a medical oncologist who actually treats breast cancer patients, I've treated hundreds of breast cancer patients in my career indeed. I have observed firsthand the heartbreak this disease has on women and their families. Over the years, I've also witnessed the advances we've made in breast cancer early detection and treatment, advances that have led to fewer women suffering and ultimately dying from this dreaded disease. I can't help but note that in our current system, our society prohibits a large number of women, 30 to 40% of those who should be getting mammograms, from actually getting mammograms. I also have to note that my own research, published and cited before this committee before, has shown that uninsured women of the same stage have poor survival compared to insured women of the same stage. That is to say that even when early detected, insurance is a prognostic factor in breast cancer. Mr. Chairman, as you know, the Society in recent weeks has publicly disagreed with the recommendation of the U.S. Preventive Services Task Force with respect to mammography. Let me say right now that I have tremendous respect for the task force. As an academic physician, I look forward to virtually everything that the task force has published over the last 20 years regarding cancer. I also want to say that reasonable experts can look at the science and disagree. There is useful screening that should be done and useless screening that actually can be harmful. And that is something that the task force, I think, should be looking at in an objective fashion and actually has generally done a very good job of doing. With respect to mammography, the scientific evidence supporting its value in reducing deaths from breast cancer is quite strong. In looking at the evidence, the Society, along with other medical groups, believe that screening mammography offers an identifiable and important survival benefit to women in the age group 40 to 49 and indeed women age 40 and above. More specifically, the Society believes that the reduction in mortality and less invasive treatments associated with early detection of breast cancer using mammography continues to warrant a recommendation of annual screening for all women beginning at the age of 40. We do agree with the task force that women should be informed of the potential risks as well as the potential benefits of the procedure. The data and literature examined by the task force in the lead up to its November announcement on mammography is essentially the same data reviewed by an expert panel of breast cancer researchers, clinicians, and epidemiologists convened by the American Cancer Society in 2003. However, in that earlier review, the Society's panel considered the additional findings of a population-based study of modern mammography, which showed much stronger benefits from screening compared with the more limited data examined by the task force. Translated, we actually think there's a greater benefit to mammography screening than does the task force. In addition, since that time, a number of advancements have emerged that have shown to increase the effectiveness of mammography for women aged 40 to 49. There have been improvements in the quality of mammograms resulting from the Mammography Quality Standards Act, or MQSA. There's been a shift to using digital mammograms over film mammograms, which research indicates may be more effective in screening younger women with denser breasts. The introduction of new technologies such as magnetic resonance imaging has also proven to be a particularly effective tool in high-risk women. Let me be very clear on the next point. We understand and acknowledge that mammography screening is not a perfect test. Indeed, it is an imperfect test. But we also believe that this imperfect test is the only good test other than awareness of one's breast to help save lives at this time. We can and we must invest in research to find better tools for detecting and treating breast cancer. Women deserve a better test than mammography. Indeed, one of the great problems right now is there's a certain complacency or satisfaction with the use of mammography in women of all ages. We need a better test. The essential fact right now is mammography is one of the two ways that we can use to save lives. I have to note that there's been a lot of talk about breast self-exam, and as a medical oncologist and epidemiologist who is involved in screening and reads the screening literature, and the doctor who treats, let me say that we've been talking past ourselves when we talk about breast self-exam today. Breast self-exam, as shown in the medical literature and is spoken against by the task force, is a woman doing a specific regimented exam once a month. It actually would take about 20 to 30 minutes for a woman to do. What most of us, including the American Cancer Society, have done is moved away from that regimented breast self-exam, which was advocated 20 to 30 years ago, toward something which is a little bit different, which is women being aware of their breasts and essentially being aware of their breasts and looking for differences in their breast on an almost daily basis. This is called breast awareness. Most women indeed find their breast cancer through breast awareness, not breast self-exam. There are 2 randomized clinical trials that show that breast awareness and breast self-exam are equivalent in terms of mortality reduction, but breast self-exam actually increases the number of unnecessary biopsies done versus breast awareness. So I prefer to advocate breast awareness. I will note also, sir, that approximately 30 to 40% of American women age 40 and up are currently not getting regular mammograms. In the United States, about half of all women diagnosed with breast cancer actually are diagnosed through this breast awareness and not through mammography. For many of the women who cannot get mammography, this is the only way that they can actually have any type of early detection. In summing up, we know we can do better, and with your help, Mr. Chairman, we're heading in the right direction. The Affordable Health Care for America Act, recently passed by the House, will improve health care, and it provides a significant investment in cancer prevention and early detection by requiring first-dollar coverage for prevention in both public and private plans with little or no cost to patients. The Society and its affiliate, the American Cancer Society...
Doctor, I think you're concluding, but I know you're 2.5 minutes over.
I'm sorry. We strongly support the changes you've made in the legislation that will help the task force improve the transparency and inclusiveness of its operations. And let me just stop at that point and say thank you for asking me to appear here.
Thank you. Ms. LeRae?
Thank you, Mr. Chairman. Oh, there we go. Thank you, Mr. Chairman, Mr. Ranking Member, and members of the committee. Thank you for the opportunity to testify about the recommendations of the U.S. Preventive Services Task Force. My name is Jennifer LeRae, and I'm president of the Susan G. Komen for the Cure Advocacy Alliance. And on behalf of the patients, survivors, scientists, clinicians, and advocates of the Komen family, we thank you for holding this hearing. And I also want to thank the previous task force witnesses for their honesty in discussing how this was communicated to the public. Let me begin by stating that breast cancer experts agree far more than they disagree. This is a point that we have stressed since the task force recommendations were first released. There is no debate that mammography reduces the risk of dying from breast cancer, only debate over the timing and frequency of mammography. We don't want women to react to this latest controversy as a reason not to get screened. Komen, in consultation with our scientific advisory board, is not changing our screening recommendations at this time. We continue to recommend that women be aware of their breast health, understand their risks, and continue to follow existing screening recommendations, including mammography beginning at age 40 for women of average risk and earlier for women with known risks of breast cancer. As you can imagine, Komen affiliates have been inundated with concerns that the task force recommendations could lead to impediments to mammography. Many comments have come from breast cancer survivors who were diagnosed before the age of 50. This is a very typical one. I was 46 years old when I went in for my annual mammogram. Like so many other women, there is no history of breast cancer in my family. I was stage 2, and if not for the mammogram, I would have had much more advanced cancer. We know that mammography is an imperfect tool. But instead of stepping away from it, we must close the technology gap and come up with better methods. That's why Komen is funding promising screening research. We must work together, government, private industry, doctors, and patient advocates, to deliver screening technology that is more predictive and personalized, but less expensive. Next year, Komen will host a national technology summit, and we ask NIH to help us prepare by reporting on investments that they've made in screening technology. But let us also redouble our efforts on behalf of the 1/3 of women, some 23 million American women, who are not being screened due to lack of access, education, or awareness. We partner closely with the CDC's National Breast and Cervical Cancer Early Detection Program to fund free clinics and mobile vans. Yet the GAO found that over half of eligible women for this program do not receive screening. That's a disturbing finding that underscores the need for access to affordable insurance to eliminate health disparities. And that's why Komen supports the valuable patient protections in H.R. 3962 that would increase access to affordable health insurance, prevent insurance companies from denying coverage due to pre-existing conditions, protect patients from high out-of-pocket costs, and increase access to mammography screening. In light of the new task force recommendations, however, we must ensure that women ages 40 to 49 will have access to the same coverage and cost-sharing benefits as women age 50 and older. Even a relatively small copayment reduces mammography rates. We do understand that H.R. 3962 will create a new entity which would not be bound by the task force's guidelines, and that the bill does not exclude from the minimum benefits package services that are not rated A and B, i.e., we understand that the task force recommendations are a floor, not a ceiling. But our bottom line is that women in the 40 to 49 age group may, after consulting with their doctor, choose to forego a mammogram. But those who do choose to have one must have access to it on the same terms as women age 50 and older. The Komen Advocacy Alliance is pleased that H.R. 3962 includes patient representatives as advisors to the task force on clinical preventative services. We believe that patient advocates can help to develop and deliver effective messages about prevention and screening. We hope that these past few weeks of confusion will ultimately result in women taking more interest in their breast health, that many more underserved women will be screened, and that an intensive effort to make breakthroughs in screening technology will begin anew. Thank you, Mr. Chairman.
Thank you. Dr. Sweet?
Good afternoon, and thank you, Chairman, for this opportunity. I'm Donna Sweet, a general internist, and I'm pleased to present the testimony of the American College of Physicians. I'm a member of the ACP's Clinical Efficacy Assessment Subcommittee, which oversees the development of ACP's evidence-based guidelines, and I provide also comprehensive medical care to hundreds of patients in the state of Kansas. Because ACP does not comment on the guidelines issued by other organizations, I'm unable to express an ACP opinion of the task force recommendations, but I can speak to the college's own guideline on screening mammography in women between ages 40 to 49 years, which was published actually in 2007. We recommend that clinicians should perform individualized assessment of risk for breast cancer to help guide decisions about screening mammography, inform women about the potential benefits and harms of mammography, and base screening mammography decisions on benefits and harms of screening, as well as a woman's preferences and her own breast cancer risk profile. The purpose of ACP's clinical guideline is to facilitate an informed and educated discussion between the patient and her trusted clinician so that together they can decide on a personalized plan of screening, diagnosis, and treatment. Not all women between 40 and 49 have the same risk for breast cancer. Factors that increase the risk include older age, family history of breast cancer, older age at the time of first birth, younger age at menarche, and history of breast biopsy. In my own practice, I use ACP's guidelines to engage my female patients in a discussion. I explain that mammography, although a potentially valuable tool to screen for breast cancer, is an imperfect one. For some patients, it will detect cancer at a more treatable stage. It can also lead to false positives, which can lead to biopsies, scarring, and potential infection. It can lead to false negatives. That is, mammography does miss cancers. It may result in aggressive treatment of cancers that may never have become life-threatening. Just in the past 3 days, I've had 3 different patients coming to see me who have been extremely confused over this whole issue. I was able to speak to each woman's risk profile and discuss with them the benefits and possible harms of getting a mammogram. One was a 66-year-old patient enrolled in Medicare who had come in for her routine visit for hypertension and clearly misunderstood most of the debate. She has a history of a sister with breast cancer. We have been doing yearly mammograms, and she was worried that I was not going to let her get a yearly mammogram because of these new recommendations. Another 71-year-old came in, and she wanted to get her mammogram, which was scheduled in February before January 1st. Why she picked that date, I don't know, because she believed that the government would soon stop her from being able to get a mammogram, and she didn't want that to happen. I was able to reassure her that I did not think mammograms would be rationed. The third, however, was a very good discussion, a 46-year-old woman whose mother had breast cancer. She wanted to discuss her own risk and actually was wondering if she had to have yearly mammograms. I was able to communicate to each of them that in them they did need yearly mammograms. that we did not do things from a cookie cutter. Women should not be treated all alike. And in all three cases, as I said, they did and will get their yearly mammograms, but based on their individual risk factors and a discussion of why. The controversy over the breast cancer screening guidelines give physicians the opportunity to educate their patients on the importance of evidence-based guidelines to help them make the best choice for them. It also has important lessons for policymakers. One is that the public is ill-served when assessments of clinical effectiveness are politicized. The U.S. Preventive Services Task Force is a highly regarded, credible, and independent group of experts. Differences of opinion on the task force recommendation should be openly discussed, but it's not constructive to undermine public confidence by making ill-founded attacks on the integrity, credibility, motivations, and expertise of the clinicians and scientists on the task force. Such politicization, if left unchallenged, could result in future assessments being influenced by political or stakeholder interest instead of by science. Second, the ACP is concerned that the public is misled by some into believing that cost was behind the task force recommendations. According to ARC, the task force does not consider economic costs in making recommendations. Third, the public needs to understand that when health plans make decisions on covered benefits, they consider many different issues, of which the evidence-based guidelines are just one. Under the bill passed by the House, health plans generally will be required to cover preventive measures for which a newly constituted task force on clinical preventive services have given an A or a B. No limits are placed, though, on a health plan's ability to provide benefits for other preventive services and to consult with other sources in making such determinations. Rather than limiting access to prevention, my patients will benefit from having a floor, not a limit, on preventive services. All health insurers will be required to cover, usually with no out-of-pocket cost to them. And perhaps even more importantly, has been said here today many times, millions of women who have no access to health insurance will now have coverage and the ability to actually get screening mammograms. Fourth, we need to communicate information to the public in a way that facilitates an understanding of how evidence-based effectiveness reviews support, not supplant, individual decision-making by patients and their clinicians. They should be informed that they have the right to know about the current best evidence on the benefits and risks of different treatments and interventions. My patients have the right to know that physicians will offer interventions shown to positively impact health and patient outcomes, and they have a right to know that we will not recommend interventions shown not to provide any benefit and possibly cause harm. Patients have the right to be treated as individuals with their own unique values and personal risk characteristics instead of being asked to follow one-size-fits-all treatment protocols. And they have the right to know that the evidence comes from respected, independent, and credible clinicians and other scientists protected from political and other stakeholder pressure. And I thank you for this opportunity.
Thank you, Doctor. Ms. Visco?
Thank you. I'm Fran Visco, president of the National Breast Cancer Coalition and a 22-year breast cancer survivor. As you know, NBCC is a coalition of hundreds of groups from around the country dedicated to our mission to end breast cancer. One of our roles is to train advocates to understand the process, concepts, and language of scientific research. We analyze scientific information for our members and the public from the perspective of lay advocates. Our number one priority for many years has been guaranteeing access to quality health care to everyone. We believe we cannot achieve our mission without it. We've been working with Congress and the administration on this goal based on our framework for access to quality health care, developed over a number of years of hard work by our grassroots leadership, and a key component of that framework is making certain that trained consumers have a seat at every table where decisions are made in healthcare policy. We believe in evidence-based approaches to health care as a key to quality care. So what is the evidence behind mammography screening? As we are all well aware, and as many people have said, mammography has significant limitations, and there has been much controversy over the years about screening programs. At what age are they effective? How do we balance risk and benefits? How can we communicate the very real limitations of screening and the harms associated with it? In 1997, an NIH consensus conference recommended against routine screening of women under the age of 50, but political and outside organizational pushback, not evidence, torpedoed that recommendation. So in fact, we have known the issues with screening for decades. We also know that 40,000 women will die of breast cancer this year. Tens of millions of people in this country are uninsured. Many, many millions lack access to quality care. We know we have a great deal of work to do to fix this situation. We know that breast cancer is a complex disease, that while we have learned more about the biology of the disease, in the 4 decades since mammography screening programs have been instituted, we have not yet learned how to detect life-threatening breast cancer at a point where we can make a difference, how to cure it for every woman, how to prevent it. Given all of this, we were frankly stunned at the reaction of the media and many in the cancer community and in government to the task force recommendations. The task force is a body of the right experts who look carefully at updated evidence and objectively made recommendations not that different from their prior recommendations. Given all of this, the amount of time and attention given to these revised recommendations seems just a bit unseemly. The public has increasingly put their faith in screening and early detection, even though we've never had good evidence that this would have a significant impact. But too many did not want to highlight the known limitations of mammography. They wanted simple messages. Once a year for a lifetime, early detection saves lives. The overemphasis on the importance of screening caused some people to state over and over again that mammograms prevent breast cancer. And please, let's be very clear, mammograms do not prevent breast cancer. We had hoped that the task force recommendations would cause all of us to stop and think about screening, take the time to look carefully at the evidence, and put screening and its limitations into proper perspective, and that can still happen. It's important also to put this in the context of the population we're screening. Screening programs are for a healthy population, for the millions and millions of women, the vast majority of whom will never get breast cancer. The question then is how we devise a screening program that appropriately balances risks and benefits for these healthy women. So what did the task force actually say? To women in their 40s, they said there are benefits and harms from mammography screening that you should know about, and you should make an individual decision at what age you will begin a screening program. So the task force actually recommends giving women control over their own health care decisions. On self-examination, Dr. Brawley pointed out that the self-examination touched on by the task force is that routine, regimented, monthly search for cancer. It has been represented as saying that women shouldn't know their bodies. Of course they should. This isn't about that. Some are concerned that the new guidelines will prevent underserved women from entering the medical system at all, and we would counter that the solution to that is to enact universal access to health care for all, not to depend on a faulty test that exposes women to radiation and the risks of false positives in order to get them to a doctor. Disadvantaged women deserve the same access as all other women to quality, evidence-based care and the right information. We do need to move forward because none of this is good enough for women. We can use this, and we should have used this, as an opportunity to educate the public about science, about evidence-based care, to help alleviate the unwarranted fear, not feed it. Some argue that public health messages need to be simple, and changing guidelines will confuse women. We would argue that while messages need to be simple, they need to be truthful. Women deserve the facts. We've all heard from women over the past month who are outraged and who believe that a mammogram saved their life. These anecdotes are not evidence. They may be compelling soundbite, great media stories, but they're not evidence on which we should base this nation's public health agenda. That should be based on the type of scientific work done by the task force. We can't believe in science only when we like the answers it produces. I want to end with an anecdote. Carolina Hinestrosa was the executive vice president of the National Breast Cancer Coalition, and her breast cancer was detected early, in her late 30s. Probably was not life-threatening, and she had treatment. She died this past June as the result of her treatment. Her story and all of the anecdotes just tell us how little we know about breast cancer, how we need to be so very careful about evidence and push for the right answers, no matter how unhappy we are with what those answers are. Let's save our outrage for the reality that we know too little and women deserve so much more. Thank you.
Thank you, and we're going to We'll try to get this done before the votes. I don't know if that's possible, but I'll start with myself. You know, I really want to apologize to you, not, you know, maybe on behalf of Congress, if I could do that, because, you know, I was listening to what Dr. Sweet said, and you're absolutely right that this has been totally politicized, and I guess, you know, the problem is that, you know, Congress is political, and maybe this isn't the, you know, the vehicle for it. I mean, it's sort of interesting to see that in the first panel, most of the members were here, and most of the media were here. Now we're on the second panel, which is not the political panel, and the situation is reversed, you know. And Ms. Visco talked about how essentially, and I don't want to put words in your mouth, but you know, after listening today, I can't help but say I'm not sure there really was that much of a difference between what the task force said now versus, you know, what the recommendation was a few years ago, or even between what you're saying and the previous panel said. It's just amazing how, you know, these differences, if there are any, have been exaggerated and politicized. But I guess that's just the nature of the process around here. So I don't know what we can do about it or make it any different. I say that, you know, out of sadness, really. But let me ask you just a couple questions because I know the time is running out here. And I'll start with Dr. Brawley and also Ms. LeRae. A few days after the task force recommendations, the Cancer Society issued a statement urging that healthcare reform create a transparent and evidence-based process for making task force recommendations. And I guess Coleman echoed those concerns. But your statement, Dr. Brawley, listed a number of changes you'd like to see in health reform, and you discussed the importance of transparency in the task force's process of arriving at its recommendations. Now, I believe that the bill, H.R. 3962, actually addresses those concerns. So I wanted you to really, you know, answer that. I mean, this importance of stakeholder input and those recommendations you made about that, does the bill, H.R. 3962, address those concerns?
Well, sir, I believe that it does. I think the most important thing is that the task force continue to provide objective evidence, but also provide the objective evidence in an open arena where people can actually see the process.
Okay. And then, Ms. LeRae, from Coleman's perspective, do you agree that the provisions in H.R. 3962 would improve the task force recommendations process? I mean, you don't have to just say yes or no, but go ahead.
Sir, actually, yes. I mean, H.R. 3962 has a stakeholder panel that would advise the new Clinical Services Task Force, and we think that makes a lot of sense. We think such a panel, I think, could have helped to really communicate the findings of this task force, and even though people might not have, there still may have been disagreement within the scientific community, I think the message could have been delivered in a way that was much more helpful to women and their providers.
Well, I want to thank you. I just was trying to make the point, really, that the issues that the American Cancer Society and Komen raised months ago, well before these task force recommendations emerged, you know, that we felt on the House side we were listening to, and I'm trying to point out that as a result of your efforts and this collaboration, you know, that the bill contains the changes to the task force necessary to improve the process. That was my only point. And then the second one, and I'm going to ask all of you this quickly, and that is, as you know, my colleagues on the Republican side have repeatedly raised concerns about the House-passed health reform bill in light of the task force recommendations, and they've repeatedly asserted that H.R. 3962 somehow, well, I don't want to put words in their mouth, but I think there's a suggestion that somehow the bill, you know, is a step backward on the issue of breast cancer or breast cancer screening. So I just want to ask each of you is, you know, on the whole, do you think the House-passed health reform bill, H.R. 3962, is actually more helpful, or is a step forward or a step backward with regard to women with breast cancer and these screening issues? And I'll just ask each of you to comment on that briefly.
Mr. Chairman, if I can just say, there are thousands of American women who die today because of lack of access. There are thousands of women who die today because they are detected early, but they don't have insurance that get access to reasonable and good care. Any effort that gets those people reasonable and good care is a good effort that's going to save lives. We've been talking about the number of lives that would be lost through this recommendation of, maybe it was a recommendation not to get screened for women in their 40s, maybe it wasn't. But the number of lives that we could just fix, that we could just save through a logistical fix is tremendous. Just get them access to care.
Ms. LeRae.
I would add, in addition to the universal access that Dr. Brawley mentioned, also the limitations on pre-existing conditions and out-of-pocket costs are currently a huge burden for breast cancer patients, and one of the main items that our advocacy community throughout the country asks that we follow very closely in healthcare reform, and those protections are included in H.R. 3962.
Dr. Sweet, thank you.
Absolutely. This bill will help the health of American women with and without breast cancer. There are a number of women who do manage to get diagnosed and then have no access to reasonable care, as Dr. Brawley said. The number of women, even in my own practice, that are locked into jobs that they would rather not stay in, they can't move because of lack of health insurability. They know if they leave their job and leave that health insurance, when they try to get the next one, they're going to be uninsurable. And I think the fact that this bill addresses getting rid of pre-existing conditions and guaranteeing health insurance to all at a reasonable cost is extremely important. And then the third thing is the bill does address some of the healthcare workforce issues. Access means having a trusted clinician, as the woman from Florida said, and there are not enough of the primary care people out there anymore to be trusted clinicians for all the people we're going to give access to. And your bill does put in provisions to have an improved, I think, primary care workforce by improving payment and other things. So I think this bill is an absolute improvement. The millions of lives that we lose because of true lack of health insurance is much, much greater than what we're going to lose by a few women who decide not to have screening once they think about it.
Thank you. Ms. Visco.
Well, as you know, Mr. Chairman, the National Breast Cancer Coalition has endorsed the bill, the House bill, and we completely support it. We believe it is an incredibly important tool in eradicating breast cancer. We think it will move us forward tremendously in getting everyone access to health care and helping save lives from breast cancer. And I hope that this controversy does not cause the Congress to interfere in any way with the independence and objectivity of the task force. We cannot allow that to happen. We need evidence-based quality care. And I also truly wanted to ask the question that if the bill was changed to mandate C-level recommendations in a basic benefit package, if everyone who spoke to that issue today would then support the bill. I tend to doubt that. So I really think that if we want to save lives, if we want to move forward, if we want to end breast cancer, we need guaranteed access to health care reform, and the House bill is very important to achieving that end.
Thank you. Let me mention, I was under the impression we had votes. In fact, we're in recess on the floor, so there's actually not any real time constraints here. Chairman Dingell.
Panel and congratulate them for their very fine presentation. I'm going to begin by reading something which appeared, and you'll recognize it, in the statement of Dr. Sweet. Under Affordable Health Care for America Act, H.R. 3962, passed by the House of Representatives, a new task force on clinical preventive services would be created, which would take on many of the responsibilities of the current U.S. Preventive Services Task Force. This new entity will have an important role in making evidence-based recommendations on preventive services that insurers would be required to cover, but the only binding effect the recommendations of the task force will have on health plans is a requirement that preventive measures for which the task force has been given an A or B rating must be covered. The bill does not give the task force or the federal government itself any authority to put limits on coverage, ration care, or require that insurers deny coverage. Health plans could offer additional preventive and other benefits of their choosing, and no restrictions would be placed on their ability to consider recommendations from sources other than the task force in making such coverage recommendations. And now, if you please, starting with you, Dr. Brawley, do you agree with that statement?
Well, sir, I'm not a policy person. I'm just a
Yes
simple
or no?
doctor, but I do agree with your statements.
Thank you. I'm not trying to lay traps here. I want that clear. Ms. Laurie?
Yes, Congressman, as I said in my testimony, we also see the role of the task force as creating more of a floor than a ceiling. So in that sense, I would agree with you.
Obviously, Dr. Sweet, you agree.
Yes, I agree. And I have some very good policy people behind me that agree. That's important, too.
I'm just trying to lay to rest some of the nasty untruths that are being circulated about this legislation. You, Ms. Visco?
Yes, I agree.
Now, each of your organizations has supported the legislation H.R. 3962. Do you have any apprehension that the provisions that we are discussing today or any other part of this legislation will trigger a nasty program of rationing health care?
No, sir.
Ma'am?
No, sir.
No.
Doctor? Ms. Visco?
No.
Mr. Chair, I guess that's all the questions I've got. I think we have laid to rest some of the unfortunate misapprehensions of our colleagues, and I can only express my great regret that they're not here to participate and to learn from the wisdom of our witnesses. Thank you, Mr. Chairman.
Thank you, Chairman Dingell. Mr. Green.
Thank you, Mr. Chairman. I apologize for being in and out, but we have both Secretary Gates, Secretary Clinton, and the Joint Chiefs of Staff and the Foreign Affairs Committee talking about Afghanistan. So although this is such an important issue for the district I represent a majority Hispanic district that is also a federally medically underserved area. And we face many, many issues when it becomes to encourage women to seek primary and preventative care services. We rely on our Harris County Hospital District and our community-based health clinics to provide the services and screening for our constituents. I worry that the revised recommendations will discourage these safety net providers from aggressively educating and screening for breast cancer in these underserved populations. I often say we have one of the premier medical centers in the world, including MD Anderson Cancer Center, located in our backyard. But my constituents can see the medical center. It's just hard for them to get there because they're substantially uninsured. And unfortunately, most do not have the access to the medical services. Could you briefly speak about the current access barriers for breast cancer screening minority and those residing in medically underserved districts face, and what impact these recommendations may have on these populations? Dr. Brown.
Well, Congressman, I hope the recommendations of the task force will have very little effect on your constituents, with the except that perhaps the discussions that we've had in the news over the last few weeks will bring breast cancer much more to the forefront. I have some hope. I said in my testimony about half of all women in their 40s and 50s who are diagnosed with breast cancer are actually diagnosed not through a traditional breast self-exam, but through what we prefer to call breast awareness. They notice it when they're getting dressed or when they're in the shower, that sort of thing. Perhaps people will hear what this national conversation we've had and actually be a little bit freer to come forth and get evaluated by a doctor should they find an abnormality. I also hope that people will continue listening to the other organizations like the American Cancer Society that have said that women age 40 and above should continue getting mammography on an annual basis. But also I think it is important to realize that there is controversy about how good mammography is. And as I'll just leave with one last statement. Mammography is imperfect, but right now it is the best technical tool that we have other than awareness for early detection.
The mammography is much more valid than the PSA test is for males.
Oh, sir, yes, absolutely. You are absolutely correct. There are 9 studies in the literature that show that mammography saves lives. There are 2 randomized trials on PSA, one that shows it saves lives and another that fails to confirm that first finding.
Okay.
Congressman, I'd like to comment on that as well. As you know, we partner closely with the CDC and other providers to support free clinics and mobile vans in districts such as yours. And so we're very familiar with the kinds of constituents you have and really a very fragile relationship they have with the healthcare system, many of whom are uninsured. And so we've been working very hard in these last few weeks to make sure that the hullabaloo around the release of this recommendations doesn't cause women who really already have that fragile relationship, who may just be coming into mammography clinics for the first time in their lives, to say, well, gee, maybe I don't need to come at all. So we're working very hard to ensure that that message doesn't get twisted around and be taken as a sign that mammography can provide help to them.
And I would hope, as a clinician doing this, just as in my practice, women will come in talking about it. There is nothing more likely to get a patient to bring something up than to see it on CNN or in the controversial position, and maybe it will sort of nudge many of our clinicians who perhaps haven't taken the time to have that discussion to actually make it an individualized, personalized discussion with that woman about what she needs, along with the fact, as we said earlier, that many of those women, if health care reform can occur, and we do have access to health insurance for the poor and the people who need it the most, we will be able to offer screening to some of these women in a clinical situation that have never had that available. So I truly see this as a critical time. And the hullabaloo, it is a political sort of system, and there's a lot of things out there that just aren't true, I think. But it does bring women to discuss it. And once they bring it up, then the doctor, the clinician, has to follow through.
Thank you. Ms. Visco.
Yes, we are working very, very hard on making certain that everyone in this country has guaranteed access to quality health care, and that will certainly solve the problem. We're spending the majority of our resources on that issue. There are also a number of studies out there looking at what are the barriers to access for underserved population. Why do they not access the healthcare system? And of course, one of the reasons is because they don't have coverage for treatment. That's why the National Breast Cancer Coalition a number of years ago worked very hard to get enacted into law the CDC Breast and Cervical Cancer Treatment Act, because we knew that screening, even if you do get a mammogram, you have to have access to treatment if you want to save a life. And so that is our number one concern, and that is where we focus most of our work.
Thank you, Mr. Chairman. I know I'm out of time, but appreciate you. My concern about the furor over this is that women will make that decision not to. And again, early detection is still the answer, and particularly in underserved communities. So thank you, Mr. Chairman.
Thank you, and I think that concludes our questions. I just want to thank all of you again, and once again, as I said to the previous panel, you certainly cleared up a lot of the misconceptions. I just hope we can get that message out to the media, which is often difficult. But thank you. You may, some of the members may submit written questions, and we try to get those to you within the next 10 days. So you might get some additional questions, and of course the clerk would notify you of that and the time period to get back to us. But I do want to thank you again. And without objection, this meeting of the subcommittee is adjourned. Thanks.
Oh, excuse me. I cut you off at the knees here.
Very